Welcome, everyone. Thank you all for joining us for this webinar, which is part of our series of presentations funded by the Australian Government Department of Health, Disability and Ageing. And what these webinars and webinar series are all about is how to apply evidence into practice as part of our Comorbidity project. My name is Christina Morell. I'm an Associate Professor, Deputy Director of Treatment and Translation Research and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use here at the University of Sydney, where I also lead the Comorbidity project and work with an amazing bunch of people. And several of those amazing people are joining me here as we bring you today's webinar, which is being presented by Dr. Robert Fullerton. And if you're able to stick around to the end today, our marvellous trainer, Sally Boardman, will be facilitating the discussion with Robbie. And before we get into that, I would like to acknowledge and pay respects to the traditional owners of country on which we're meeting and recognise that we are joining from many traditional lands across country. The traditional owners of the lands that I'm currently on are the Gadigal peoples of the Eora Nation. I would like to acknowledge the traditional owners of the lands that you're all joining from and pay respects to elders past, present and emerging. I'd also like to recognise and acknowledge the many people with lived and living experience of mental health conditions and substance use, as well as their families, carers and loved ones, many of whom have generously contributed to the development of the guidelines on co-occurring conditions, as well as our other resources. Whether you're joining us live or watching the recording, you're all in listen-only mode, which means we can't see or hear you. So just to draw your attention to the Q&A and chat buttons on your screen, if you have any questions for Robbie during the presentation today, please feel free to use the Q&A button. If you have any comments or anything other than questions for Robbie, can you please use the chat? That just helps us keep track of what questions we pass on to Robbie or whether there are other requests for support or technical issues that we will assist with. Both the slides and the recording for this webinar will be available to download from our website in the next few days. Before I introduce Robbie and hand over to him to get started, I just want to mention that you can access our webinar library and register for our next webinar at our website. The link to do that is on the screen and we'll put that in the chat. And if you have a few minutes at the end of the webinar today, can you please take a moment to let us know if you have any feedback or suggestions for future webinars that you'd like to see be part of this series? And thanks very much to those of you who have been sending through feedback and suggestions. We're making our way through those and we'll see what we can do. And now it's my very great pleasure to introduce our presenter for today, Dr. Robert Fullerton. Robbie is a senior clinical psychologist at Sentient Professional Wellbeing. He holds a dual PhD in clinical and industrial-organisation psychology and has 16 years of experience applying motivational interviewing in government-funded university counselling and private practice treatment settings. Robbie is dedicated to building collaborative therapeutic partnerships with clients based on respect for their autonomy, compassion for their ambivalence around change, and belief in the personal strengths that they can leverage in service of changing patterns of behaviour that compromise their well-being. Some of you may know that Robbie presented a webinar with us several years ago and we had just started this series and many of us were in COVID lockdowns. So even though that webinar is still part of our library, we asked Robbie to come back and I'm so very pleased that he agreed. So thank you so much again, Robbie, and I'll hand over to you to get started when you're ready.
Oh, thank you very much, Christina. I'm just going to go ahead and share my screen really quickly. Well, welcome everyone. Happy Friday. I'm going to be talking about how to support client change with motivational interviewing today. So it's a very vital treatment philosophy, modality, and skill set that we should probably be applying with a lot of our clients. It does span across modalities. You could be using motivational interviewing in tandem with other types of treatment like CBT, DBT, etc. But especially when you're working with drug and alcohol or any other type of addiction, it's really important that we keep some of these principles in mind. So I'm very happy and I'm very passionate to share this with you. The learning objectives today are going to be to understand the trans-theoretical model of change. So it's a model of change that discusses what people might be going through at different stages. And I'll go into that. Understand what motivational interviewing is and when it is useful. Gaining knowledge of the spirit and the principles of MI, and learn some of the core skills. So we'll get to a chance to see those and practice them. First of all, I'll be discussing motivation in general. So motivation is a very strong predictor of change. A lot of times you'll notice the best type of motivation is intrinsic. You can't really force anyone to make changes. They have to want to make them themselves. And that can be very frustrating when you think you know what's best for them. You have their best interests at heart. You give them the right advice, but you don't see them taking that advice, and they're not doing anything on their own volition. However, when clients are motivated, you'll notice increased treatment participation, which can yield positive treatment outcomes. The desire to change is a continuous variable rather than dichotomous. It's not like you either are really motivated or not at all. People will go through different stages or different degrees of feeling motivated toward making changes. And ultimately, the practitioner and the client both contribute to the patient's motivation to change through the therapeutic interaction and the partnership there. So there's a little quote down at the bottom of a slide from Stephen Covey, who some may know wrote The 7 Habits of Highly Effective People. And it says, motivation is a fire from within. If someone else tries to light that fire under you, chances are it will burn very briefly. So the quote illustrates that it's not just about lighting a fire under the patient, telling them all the bad things that's going to happen to you and the consequences, but more to the point, they need to figure out how to light that fire within, and you can be a guide in that process. They need to want to change in order for change to happen. There is a large evidence base behind MI, and they've been seem to have positive results in numerous controlled studies, addressing different types of changes that people might need to make, both on their mental health or their physical health. So, substance misuse, eating disorders, pain management, um, even dietary or dentistry, dental health, HIV, AIDS risk behaviors. So they have looked at this from a lot of different perspectives and found that a short intervention using the principles that we'll go over today have been effective in treating these different issues. There is one systematic review and meta-analysis I want to go over. It's from the British Journal of General Practice, and they found that MI was significantly better than other approaches in 3 out of 4 studies and outperformed just traditional advice giving 80% of the time. Typically, that was in like a GP setting or like a doctor surgery. But even brief encounters of about 15 minutes or less in 64% of studies showed a lasting effect using MI. So we don't even need a full session, but we do need to apply some of these things. And particularly if you only have a bit of time, maybe it's a crisis management situation, or you only see clients for about 20 minutes, it's still shown to be effective in those doses. Now, what do we bring to the table? The kind of characteristics that you need to practice MI are kind of general counseling characteristics. So, practitioners, we need to be empathic, have a sense of warmth, and be very genuine with the client. We need to bring our authentic self with us as well. Empathy may be defined in many ways, obviously, but the creators of motivational interviewing have defined empathy as the show of skillful, reflective listening that clarifies and amplifies the client's experience and meaning without imposing your own material onto them. So I know it kind of goes against the grain in some settings that you might work for, like you're the expert, you need to be telling them what to do or giving them all this information about why they need to change. But ultimately, they know partially that they need to change for some reason, otherwise, they might not be in your office. And they are the experts in their own life. So we need to be able to understand them, create space for them, and just sit with those different things that they're struggling with. And the beauty with MI is in that empathy, you don't really confront in a way that's trying to correct the behavior, but out of curiosity and not judgment. So we'll talk about how that comes up in the room. One of the main characteristics of working with a client and using MI is paying attention to ambivalence within the client. So there's a reason we don't really change our ingrained habits. We're highly motivated not to change for some reason, yet we can sometimes see the benefits of changing. So it's a little bit like a seesaw. And now, if a patient's in front of us and you see they're engaging in some behaviors that are compromising their health, or you see risky substance use and that's had negative consequences to them, you can point out all the negative things and all the things that maybe even themselves know are reasons to change. But there's a whole host of things that are counterbalancing that, that may be a source of comfort for them or providing emotional regulation, and are motivating them not to change. So that's kind of what we're up against, and we need to be able to pick up on the ambivalence and know where we stand on this bit of a seesaw. Fundamental to motivational interviewing is to acknowledge that ambivalence is a natural part of the process, and we need to explore the ambivalence with the client rather than just weighing down one side, like you need to change because XYZ. It's let's look at the whole picture you're struggling with. Let's both be curious scientists to figure out where do we go from here. What we really want to avoid is speaking in a way that might be judgmental, moralizing, shaming, commanding, like with a lot of authority or hierarchy, or even threatening the client to kind of do what you want or do what you think is best for them. You might have already seen this, but because this is an introductory webinar, I do need to go over the stages of change. This is really helpful to understand where they are in the process of considering whether they're going to make a change or if they've made a change. So in order to move people from not wanting to change to wanting to change, we need to understand the various stages that you see on your screen now. Um, and it's not really a perfect stage model because it's not meant to imply that once you get through one stage, you're done and then you go on to the next stage. Because as you can see in the middle, sometimes you could kind of go back into other parts of the model. But the different concepts are things that you're going to want to understand and evaluate when you're in the room with the client. So one is pre-contemplation. That's not having any intention to change. They may even be in complete denial that they have a problem and they don't want to acknowledge it. Even if they're in your rooms doing counseling, but they're like, you know, my wife made me do this, or my doctor said I had to, or I'm court mandated or something. And we all kind of know that is a bit of a frustrating presentation, especially if they're not keen to be engaging in a lot of the therapy that you're offering. But there'll be some things that we talk about to try to move them into more contemplative stage. So the contemplation stage is where the patient knows that they have a problem, but there's no commitment to action. There's actually a lot of that ambivalence. Maybe I need to change. If I don't really want to, I need a bit of guidance, or maybe I should just keep things the same. You can see them really stuck. But that's kind of the best place to catch a client because there's a lot of ways in the following slides that we'll talk about trying to move them from that contemplative stage to preparation. So preparation is an intent to make a change, but they haven't taken action yet. So it's like a planning stage. What are all my resources? What are my options? Let me think it over. But at least they're spending more time thinking about making a change rather than being stuck in that limbo. Then we go to action. Action is just simply they've committed to changing and they're taking the steps that they planned in preparation to follow that action plan. And then maintenance is they've taken steps to change and then they've noticed some results and it's having this reinforcing effect where they want to keep going. And in that particular stage, your job is really to support them in maintaining the change and the progress, but also looking out for any warning signs that they might be slipping, maybe leading to a lapse. I don't really like the word relapse, but it shows up in this slide. But a lapse or recurrence is a natural part in this cycle. And we should highlight that to clients because they can get really disappointed in themselves for having a slip up. And shame's just going to be detrimental to the process of change in general. And if you normalize that at some point there might be a lapse and it's our job to learn from it, but it's part of the journey, then it takes a bit of the pressure out. It also follows the harm reduction model rather than the more kind of black and white abstinence only model. We're not encouraging them to have a lapse, but we're saying we're not going to judge you, demoralize you if that were to happen, but we're going to try to prevent it as much as you can. But, you know, I'll be there regardless of where you're at in your journey. So I'm going to go over these in more detail with a couple of examples so you know what they look like. Pre-contemplation, as we said, is not considering a change and little awareness or concern of the negative consequences. An example might be my blood pressure readings have been a bit high, but I feel fine, so I don't think I have a problem or it's a problem. So not a lot of motivation to change there. They're almost kind of shutting you out if you're the healthcare professional, like, I'm going to minimize how much this is an issue. So you can already tell they're not going to be as open to your suggestions. With contemplation, there's a little bit more openness. There's an acknowledgement that you could make a change, and it is characterized by that heightened ambivalence. So you seesaw between the reasons to change and the reasons to stay the same. But staying the same might have gotten a little bit too uncomfortable, or there have been too many consequences. So they're having to entertain the reason to change on their own. Um, an example would be, I can see that it would be better for my health if I quit smoking, but it's my only break in the day when I get some quiet alone time, which I get a lot, especially with smoking and people that takes smoking breaks or smoke on their lunch break. And there might be valid reasons why they need to change. Maybe they're getting some feedback from their health professional, their doctor, um, but they haven't developed the emotional regulation strategies. So it feels really embedded, you know? And they don't know that they're actually just using that as a coping strategy. They just know that it kind of calms them down. They're not entertaining the other options. And that's where we can kind of use this as a springboard of let's be curious about what other options we have. Preparation, that's your window of opportunity to kind of strike and plan for action. It's where the balance has tipped into that, no, maybe I really do need to make a change. I'm open to hearing what you think I could be doing, what action steps are available, what resources you might be able to offer me, and what it might look like. A client would say, I really want to lower my cholesterol. I just don't know how to go about it. Great. Well, you're expressing curiosity, and I have a lot of different resources. Would you be interested in going over some of those with me? One of the other things I should probably mention is once you see someone kind of teeter into that, I might want to make a change. What would that look like? Always ask for permission or kind of propose, would you like to go over that? Can I give you some resources? Again, and I'll get to this later, we want the client to feel like they're directing the conversation and you're just guiding. And then they have self-efficacy in whatever decision they make at the end of the conversation. So asking permission and consent for giving advice is actually kind of a form of empowerment and letting them know, I'm just here to help you and you're still in control. It kind of lowers the amount of hierarchy or the power dynamic as well. So you're just two people having a frank conversation about how they feel about the behavior, what's been going on, and whether they think they should make a change. But you also are the expert in the room that has more resources and insight into what the possibilities are. Action. We love when clients get into action. It's when they engage in certain behaviors designed to bring about the change that you've been discussing. So maybe you've offered suggestions and they've pursued them and ultimately made plans or acted upon them. May happen with or without your assistance. Sometimes you plant the seed, maybe you don't see them for a bit, and then they're like, actually, I want to re-engage because I did actually go to that class or group, and I think this is going to be good for me. But there's determination produce the change. So it comes from them. What that might look like is after our last visit, I actually did book in to see that psychologist for my anxiety, like we talked about. In maintenance, as we talked about before, you're trying to sustain the change and also kind of keep relapse at bay. You're just affirming the actions that they've taken. If they're struggling at all, you're going to talk about any difficulty sustaining that change, go over what that might be and how you overcome some of the barriers or hurdles that they're facing to stay with that new behavior change. But then always looking out to the risks for them to lapse, or if you do see that their distress level has kind of gone up and down, you might use that as an indication that if it really gets a little bit too much for them, they might slip back into the old method of self-soothing or coping, which might be a substance or it could be anything addictive, binge scrolling, just like I don't know, watching too much Netflix, whatever behavior that is just like it feels soothing, but it has this addictive quality because it's overcompensating for the fact that they are overly distressed and they're not self-regulating. So one of the examples there is the last few months on these medications have helped, but I'm wondering if I really need to keep taking them. So now they're kind of questioning. So that's an opportunity to remind them of what got them on the medications in the first place, how helpful they've been, um, and then some of their concerns realistically about why it's difficult to consider keep taking them. The next one is lapse. So having a lapse, like we said, is supposed to be framed within the MI framework as normal and expected, but obviously not encouraged. It's just acceptance that it might happen. Um, this does fall within the harm reduction or minimization approach to substance use or any treatment of any addiction. And it's not necessarily about making sure they stay abstinent forever, which would be great, but realistically, maybe not feasible for the particular client. And we have to acknowledge and learn for that experience. So I'm going to go into one of the examples, sorry, is I've slipped up over the holidays and had a few drinks at a work Christmas party. And I've gotten that before, someone's getting married or there's a bucks or um, Christmas party. People tend to be a bit looser there. So now I'm going to run you through a activity. So that's just a reminder of what the stages are if you want to get kind of sear that into your brain before we go to the next slide. And then here, this is the exercise that basically allows you to kind of match the client statement with what stage of change you think that client might be in. So, and feel free to give me some feedback in the chat. I have that running on the side. So I'm going to read the quote and then just kind of tell me what you think the stage of change is. I think I will book in to see that psychologist you recommended. And it is very difficult to put them in completely discrete terms because I know that I'm seeing some actions, preparation, a couple contemplation. Yeah. Yeah. So again, it's not always so cut and dry because obviously they're contemplating a change. This is about potentially taking action, but not having taken it yet. So we would put that under preparation. But again, like if you said contemplation or action, it's pretty close. But for the sake of specificity, that's where I would put that. Um, Over the summer, I started going to Zumba classes on Wednesday nights, and I'm really liking it. So where do we think that person is? Great. I'm getting a lot of action and maintenance. Yeah. So you could think of it as action. I think because maybe it's a change that they've already made in the past and they're maintaining it, that's why I would put it in maintenance. Again, we might be splitting hairs, but yeah. My weight isn't a problem. And their BMI is 31, their waist is 100 centimeters. Yeah, it sounds like a lot of people have had a presentation where people are denying they have a problem. Because I think most people got pre-contemplation down there. Yeah. I've started using nicotine patches to help me quit smoking. So I've started using them. Yeah. Resounding action for sure. So this is similar to the other example. I slipped up and have gone back to drinking since the Easter holidays. Yeah. Wonderful. And then even if it's just process of elimination, I know my sugar levels will be better if I stick to a diet, but I don't think I can give up sweets. Yeah, and I want to highlight something here. You'll get this double-barreled kind of, or the seesawy kind of comment around like, I know, and this is why I should change, but there's always kind of a but, and then this is why I'm not changing. So just pay attention to that cadence in their voice and the content of what we call change talk, reasons why I should change, or what's going to keep them in the behavior. So let's get to the theoretical. So what is MI? Traditional approaches in healthcare focus on convincing the patient that that they need to change their behavior. Well, MI uses a more guiding style to help the client think about the importance and why they want to change the behavior. So not necessarily telling them what to do, giving them all the horrible things that are going to happen if they don't change, but having them reflect on why essentially it's important to them to make that change, not for you, not for their family, for them. Essentially, it's a style of communication that involves the strategic use of questions and statements to help clients find their own reasons to change. Um, it's a person-centered, evidence-based approach to treatment that elicits behavior change by helping clients explore ambivalence. So that ambivalence is kind of where the gold is, if we can navigate it. Um, and it's an empathic, supportive, yet directive counseling style that provides conditions for change to occur. Again, they keep using this language around approach and style. So it's not a modality that has a structured, um, I mean, not kind of your manualized treatment. It's more how you present in the room and using some of the principles. Now, what's the basis of MI? MI regards the ambivalence to change as natural and that we should be always evaluating as a therapist where they're sitting on that ambivalence. And when you have an opportunity, try to accentuate the reasons for change coming from them in their own words. And by engaging in that change talk, they're almost talking themselves into making that change. The ambivalence can be resolved by working with the client's intrinsic motivations and values, and the alliance between the client and the practitioner in that collaborative partnership is what brings about a lot of that change. Now, you both bring expertise. They're the expert in their own life and why it's been a problem and what's the hardest thing to overcome. You're an expert in certain things. You have these skills for in making them feel comfortable, but also you might have more resources or therapeutic tools to try to give them. But we don't want to assume that someone's ready to just grab hold of those tools and run with them. We need to make sure that it is the right time for them. So the spirit of MI has to do with a few different foundational principles. Um, Most of them are around compassion, acceptance, being in a partnership, and respect. Um, but we express, so with the collaboration, there's this idea that we are going to work together, that this is kind of a joint effort, not just me telling you what to do. Then you might need to try to focus on evoking, having them evoke. I'm going to create a space for you to share about yourself and your story with me. But it takes a lot, as you would notice in your counseling setting or whatever capacity you work. They have to feel like they can trust you. And there's a lot of rapport building that needs to happen before that. Autonomy versus authority. So I value you and respect your decisions. It's them that has to make the decision at the end of the day. So it's not you forcing the decision on them. And they're going to feel better about making the decision and feel a sense of responsibility to follow through if they're the one that actually made the decision. Compassion versus judgment. I care about your well-being and I want to understand you. Like I really want to understand you. And I respect your experience, you and your experience. So again, it highlights a lot of the different principles we talk about in other types of therapy, but MI really wants to emphasize these. The five principles very much they come from the spirit. And it's expressing empathy. So it, developing discrepancy, especially where there is ambivalence, so you can kind of parse that out and make them really consider both aspects. Avoiding argument, rolling with resistance, because argument usually stems from resistance. And instead of engaging in the argument, we need to learn tools to roll with that. And then supporting their own self-efficacy, because we need them to feel empowered to know that they can make a change and make the decision to do so. So empathy. Again, I'll just use this other definition, which I think is really helpful in understanding the crux of it. A specifiable and learnable skill for understanding another's meaning through the use of reflective listening requires sharp attention to each new client's statement and the continual generation of hypotheses as to the underlying meaning. So you're listening a lot more than you're actually saying, and you're not really telling them how they're feeling. But some of your questions might be guiding them in trying to evaluate what those feelings might be and where the conflict might be. It communicates respect for and acceptance of clients and their feelings, and it encourages a non-judgmental and collaborative relationship. Again, getting rid of that hierarchy or just trying to temper it down. Developing discrepancy. So again, you're really pointing out the ambivalence. An example would be, so on the one hand, you haven't noticed any consequences to your drinking, and yet on the other, you see your blood pressure has been quite high, which could lead to more serious health issues. So yes, you are pointing out a consequence, but you're not really saying that they have to feel one way about it. You're just kind of saying, here's the range of kind of different feelings, and it must cause a conflict for you. What do you make of that? A lot of times after making some type of reflection, call this double-barreled reflection, you might say, what do you make of that? And say, instead of inserting, this is what I make of that. Another example would be that I understand that you had some bad experience on the pill. I'm also aware that becoming pregnant at this time would pose a big problem for you. How do you make sense of this? And then the classic am I um, kind of example would be using this reflection that starts with, on the one hand, you're coughing and out of breath, and on the other hand, you're saying cigarettes are not causing you any problems. What do you think is causing your breathing difficulties? So you're kind of putting it back on them. Here's what we know. Here's what you're telling me. How are you making sense of that? Avoiding argument. Now, of course, we don't want to argue with our clients, but sometimes they're the ones that bring that more defiant type of attitude, especially if they're mandated to be there. So you might be tempted to argue in those situations, but trying to convince the client that the problem exists or that they need to listen to you is just going to precipitate or reinforce more resistance. So we don't want to make it turn into a power struggle. Um, the goal is to walk with the client, not drag them with you on where you think they need to go. So there's different types of resistance that might cause arguing, but resistance can also cause interrupting, denying, or ignoring your advice. There's ways that we can roll with that resistance, and I'll try to give you a few examples so you know what it looks like in the room. So a client might say, I don't have time to exercise. So that's, a reason I can't change. We're on that side of the seesaw. Now, the practitioner, instead of trying to say, well, you can always make time, that kind of thing, kind of take the other tack and choose empathy instead of instruction. Your life is too busy at the moment to make time for exercise. Now, I know that it's reinforcing, or it can sound like it's reinforcing the problem, but they might be like, yeah, I mean, it is busy and this is why it's busy. And they give you more information so then you can actually go deeper into, oh, okay, where are the opportunities for this, making time? Um, Another example, the client might say, I really want to start taking my medication again. And then you, as a practitioner, would say, taking your medication is very important to you. So again, it's not necessarily trying to instigate change talk. It's reinforcing that this is a value which is going to improve their motivation to move forward with the change. An amplified reflection is a little bit more intense, hence the name amplified. Um, it's almost exaggerated. So the client might say, I don't know why my wife is so worried. I don't drink any more than any of my friends. And then you might pause for a second and just think about how you want to address that. You know that their wife is concerned, so you might just accentuate that. So there's no reason why your wife would be concerned about you. So again, they would have to argue against that statement because they're in your office. The wife's probably complained. They probably told you times that the wife has complained. And you're not trying to start an argument, but you're just kind of like giving them something to talk back to you at, and then see if that's going to be something. Because, when you use those more extreme terms like no need, They have to find the middle ground in between. Another example of rolling with resistance is using a double-sided reflection. So reflect both sides of the ambivalence. I know how bad it is to keep smoking with my COPD, but I just don't know what else to do when I get stressed out. So you might use the double-sided reflection of, you can see how smoking can make matters worse for you, yet it has always been a source of comfort, and it's difficult to imagine how to manage your stress without it. Very fair. And they might be like, yes, you get it. So, and then they expand on that. And a lot of times when you give them the room to expand, they naturally kind of move closer toward a bit of change talk, which you want to then validate, reinforce. Agreement with a twist is an interesting one. So here the client might say, I can't picture myself not drinking. It's part of it's part of who I am. It's how I escape, and it helps me get through the day. So this one, you might kind of agree, but not completely. You can't live your life without drinking. It's such a part of who you are. You'll keep drinking no matter what the cost. Again, it sounds a little bit like a amplified reflection, but you need them to know like what kind of statement they're actually making without saying it directly. Shifting focus can be good, aligning and diffusing any discord, like if they are getting kind of up, they're arcing up at you. So they might say, what do you know about depression? I feel like a failure all the time. You're a doctor. Everything turned out great for you. And the practitioner would kind of just sit back, not get offended, and collect what really they're trying to express. And it's hard to imagine how I would possibly understand how much pain you're in and what you're struggling with. So you don't engage in the conflict, you actually default to empathy. I can see how you feel that way. But if you argue against it, it's just going to create more of that contention. And they're not going to want to change because they're not going to want to take your advice. They don't think that you understand them because now you're fighting with them. Reframing. Patient might say, I've tried to keep my diet so many times, but I always slip up. But you could reframe that. You're very persistent, even in the face of discouragement. This change must be really important to you. So see, they've tried so many times, and I know that they think they're a failure because it keeps not going well, but you have to reinforce their motivation, their self-efficacy, um, and try to get them back on the horse, as it were. Um, Metaphor, just using more vague language can be good. You're painting a picture for the client. I can't take too much more of this anxiety. Response might be, you want to be in a better place. Again, it's a little bit like reframing. Instead of focusing just on the desperation to take away the anxiety, you focus on, well, the desired outcome would be you'd like to be in a better place. Let's talk more about that. Now, again, this isn't necessarily always the response you want to that, but it's an MI type of moving change along. Reflection of feeling, the deepest form of reflection. So you don't repeat back their words like you would in a reflection, a normal reflection. You're just capturing the essence of the feeling state. So if I don't stop drinking, I won't be able to qualify for a transplant and I could die from this. You might say you're scared. Your drinking could be a matter of life and death at this point. Again, some of the reasons they would want to change. Supporting self-efficacy. First and foremost, you need to believe in your client. And it's hard if you get kind of burnt out at your job or you see the same type of people that come in and they're not trying to change, actively resist to sessions. It can be really wearing on your ability to maintain hope and believe in your client. But before every session, you almost have to, when you're reading through your previous note or preparing, you got to almost give yourself a pep talk and be like, you know what? I know this client can do it if they put their mind to it. And it's partly my job to help guide them there. Um, you need to empower them, foster hope, and enhance your client's belief in his or her ability to change. Identify your client's strengths and bring them to the forefront because that just reinforces that they are capable if they reflect on their strengths instead of all the ways that it didn't go well. Now, this is a very kind of important part of the skill training for MI is developing your oars. It would be pretty similar to a lot of trainings, the use of open-ended questions, so no closed or yes and no answers, trying to be as affirming as possible to support and promote that self-efficacy we were talking about, and reflective listening, which we've kind of given examples of before. Check in rather than assume you know what they meant. And then every once in a while, especially toward the end of a session, you'll make some summary statements. Just reinforce what was said, frame it the way that you think is going to promote the most change talk or motivation to change. I've just put a few different examples. I won't go through all of these. They'll be in the slide deck for you to review. But as a therapist, you might be familiar with some of these ways of just kind of opening up a conversation. What's happened since we last met? What brought you here today? How are you able to stick to that diet for 3 weeks? Tell me when this first began. So they're not like one-word answers or yes and no. Affirmations you might to pepper in. Your commitment really shows how regularly you're coming to therapy. You showed a lot of determination in doing that. It's really clear that you're trying. By the way that you handled that situation, you showed a lot of strength. And with all the obstacles you have right now, it's impressive that you've been able to refrain from using this week. Make sure that you put those in where possible, especially if they're already engaging in some change talk to reinforce it. Now, reflective listening, we've talked a little bit about that. The kind of stems that you might think about, just starting sentences with "it sounds like," so then they can clarify when you reflect if that's really true, or they can maybe give you a better understanding. What I hear you saying, or that kind of double-sided reflection of, so on the one hand, it sounds like, but yet on the other hand, and then just sit with that ambivalence with them and see how they make sense with it. Summarizing some characteristics of that is just drawing out the most pertinent points, arguments both for and against it themselves have offered. Clarify, is that correct? Do I have everything right? And ask, so what do you think we'll do about all of this? And I do have a video. Let me just see if this is going to work.
Watch what happens this time.
Hold on one sec.
Watch what happens this time when the provider cues into what the parent is saying, empathizes with her situation, and attempts to work with the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden. I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently. And I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and my having a full-time job. And so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes. Yeah. Some people have a glass of wine. I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why'd you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him. And on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right. Yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now, I don't even know how I did it. I just did it. I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what? I'm not going to risk that. So
the risks were so scary then that you're able to stop, but
Yeah.
they don't feel as scary to you now.
No, I mean, we're two separate people. And like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
yes. Yeah.
Okay. But it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I, keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's
and
on your
quitting
to-do
doesn't
list.
happen.
It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5, kind of in the unsure area. Like
Mhm.
I know I've done it before, so I know I can do it, but at the same time, it just seems really hard and it's
Sure.
not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of. I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand
Mhm.
what mommy's doing. But I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah,
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure.
So-
Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you. And sometimes just having that support can be a big part of it, especially for people like you, where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure, it feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
All right. Few things before I move from that clip. I really like that clip because you can see the clients in contemplation. They've actually quit the behavior in the past, and um, it really illustrates the ambivalence, like how do I feel about it this time? Why is it different from the last time? And the therapist, or I think in this case, the GP, was trying to accentuate, what did that look like? She used a double-sided reflection or a double, yeah. And then she was trying to elicit her own reasons for change, basically asking like, why did you quit when you were pregnant? So that would be what motivated you at that point. And then how successful were you, or why was it successful then? So what led to success? So you're kind of leading these questions. And she didn't tell her what to do. She did start saying, here are some possible options. And even the client was saying, oh, I don't like medicine. So she's still in the driver's seat of being able like to say, I don't really like that, or let's think of other things. And the therapist or the GP is just kind of moving with her. So I'm not going to go in depth. I'm aware of the time at the moment. I want to wrap up with the last couple of points. This will be in the slide deck, but for each of the different stages of change, there'll be different skills that you want to focus on. So I'll leave that for you to review. I keep using this phrase change talk. So that's any type of dialogue that you get from the patient or client that shows that they're actually thinking about making a change. Think about that seesaw. It's like, okay, we're starting to tip into I could make a change. It's based on statements around their desire, like I would like to, or I wish, or I would really want to. Maybe things about ability, like I can, I think I could. Reasons, I know my health would improve if I stopped. So, that's the intrinsic motivation. A need, like I need to do this, or my wife's going to leave me, or I need to do this for my children, or even statements around commitment, like I plan to. The way that you elicit the change talk, well, there's a lot of different things that we've already talked about, but you start asking questions about, well, what are some of the good things about using? What are some of the not so good things? So the latter is trying to get them to talk about all the things that make them want to change. An evaluation of values. A lot of times, some of the behaviors that people engage in, if they're kind of getting in the way of their health or their well-being, which could include their social relationships, they know that it's not the type of person they want to be, or it's misaligned with their values. So you want to evaluate their values and try to get them more aligned. And if something's in misalignment, you'd be like, huh, I wonder what we do about that. You could also do the letter writing, write a letter, envision yourself in 5 years. What would you have changed? How did you do it? A bit of imaginal work. And then you would have seen some change ruler work that the practitioner used in the video. So we do use scales on a scale of 1 to 10. We could measure the importance, like how important is it for you to make a change? Scale of 1 to 10. How ready are you? And scale of 1 to 10. How confident or how able do you think you would be to make that change? Scale of 1 to 10. How committed, if you were willing to make that change, how much would you commit to that? And what you might have noticed is if the client says a 5, as a general rule to promote change talk, the next question is always about, okay, why a 5 and not a 3? So a lot of practitioners might be like, well, how do we get you to an 8? Again, that's kind of imposing your agenda. And if you say, well, why not a 3? Because that's less. And then they have to come up with all the reasons or answers for why it's actually, they're more ready or it's more important. And then you feed off of that type of energy and move forward with that. So that's all from me. Thank you very much for listening. I think we're going to have a Q&A now. Hopefully we have enough time to address some of those questions.
That was fantastic. Thank you so much,
Thank you.
Robbie. I know that everybody is thanking you in the chat and found it really useful. So useful for us all in supporting our clients with change. We do have some questions in the chat, and it's probably a good time to say that we're incredibly lucky to be having you again in 2 weeks to come and do a case study discussion with us. So for everybody online, if you have questions already, or you've got time to percolate, and if you want to bring some questions to our case study discussion, or bring some cases, then we're going to have another opportunity to talk with Robbie. But we do have some questions here. It would be great to answer some if we get chance. I wonder if we could take we'll take the first one, Robbie, which is that I have many clients who might present in crisis and want to jump straight into action. So it might be seeking admission for detox, but are less open to talking about what happens after that. I don't want to discourage them from taking action, but at the same time want to slow down and maybe have a bit of a fleshed out plan. How would you work with this using MI?
That is a great question, actually, because it's funny, you get the whole spectrum, people that don't want to change at all, and some people that are a little too eager, and you're like, let's break this down a little bit. I would actually kind of focus a little bit more on their reasons for change, which is still engaging in change talk. So they might get in their head that they need to change for one specific reason. And maybe it's because they're in trouble with the law or their partner's going to leave them. But again, it can't just be like one reason. And we want to make sure that the reasons aren't just like fear-based. And that's why they talk a lot about values. So I would evaluate, how does this fit within your value system? How does this fit in the type of life that you would like to lead? And try to get them to develop the full picture. So slow them down, ask them for what all the reasons are, and, keep asking, are there any more? Is there anything else? I wonder, how does this apply to your relationships? How does this apply to work? Oh, yeah, you're right. If I were to change, this would positively impact that or that. So, yeah, really slow them down, get them to think a little bit more analytically about it, and then go into, okay, well, what would life look like in a year if you were to make all these changes? How is that different from your life right now? And where do we need to go to get there? And of course, if they're in a big rush, you might remind them that it's going to be a process, that change isn't going to be immediate, and you'll take it one step at a time. But it's better to have a really eager client than someone who's going to take a long time to go from pre-contemplation to contemplation. The other thing is values. Like, I like to use the phrase, how do you want to show up in this moment? If you have issues with like drugs, alcohol, a lot of times you're not the version of yourself that you would be proud to display to people or to be in front of your partner, your family, and keeping a list of their core values and trying to get them to reflect on how each day do I want to show up and how does alcohol or drugs fit into that, and it is misaligned, so that creates a little bit more motivation. So some of it's more practical, some of it's more philosophical, but that's probably how I would approach that client. But you're right, they do need to slow down and really break down why they need to change first.
Brilliant, thank you. And perhaps we can workshop some more of this, Emily, in the case study discussion, as we can around the really great questions about how can we adapt it for highly motivated clients, how can we adapt it for clients in a bit of resistance, and also great question around, is there any research, is there any adaptations for Aboriginal and Torres Strait Islander people? So we'll come back to those questions, guys, in the case discussions, but I'm just aware of all of our time. So Chris is going to close us out. Thank you again, Robbie.
Thank you very much.
Thank you so much, Robbie. And I'm wondering, for some of the people who won't be able to come to the case discussion, would you be happy, Robbie, if we pass those questions on to you?
I would love that. Yeah.
Okay, thank you very much. I just don't want anyone to miss out because it was so fantastic. I am going to just wrap up quickly and let you all know, for those of you who are still online, that you can find out more about find out more information about our guidelines, which this webinar series is linked to, and our other resources at our website there on screen. And for you practitioners out there, which Sally mentioned, we're really excited to be able to tell you about our online community of practice, which is where the case study will be presented through, which is also funded by the Australian Government Department of Health, Disability and Ageing. That is for professionals in Australia who work with people experiencing co-occurring AOD use and mental health conditions. It's free, and you can find out more at that link there on screen. So thank you again for having joined us for this webinar. If you're interested in having a look at our library of past webinars, watching this one again, and catching up on anything that you might have missed, sharing it with your friends and family, other people, registering for the next webinar, you can do that at the website. Our next webinar is scheduled for the 12th of August, and that will be with Associate Professor Julia Lappin, who'll be talking about drug-related psychosis, what to do and what to ask, or what to ask and what to do, rather. But until then, thank you again for joining us. Thank you again so much, Robbie. Please enjoy the rest of your day.